show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about sickle cell disease. Sickle cell disease is a very common disease throughout the world. In this country, it affects about 100,000 black folks and Latino folks in combination. Worldwide, there's about, I would say, 300 million folks who have sickle cell trait. And then in this country, as far as the trait is concerned, there's 3,600,000 folks who have sickle cell trait. The percentage of sickle cell trait is the same in black as it is in Latino, 8%. 8%. Now, what is sickle cell disease? Sickle cell disease is a disease that results from the malformed shape of this red blood cell that you're looking at, the banana shape, like this, the half moon shape. These cells are mal-shaped, they're very sticky, and they cause clogging of the vessel during circulation, impeding the delivery of oxygen to the tissues in the body. What happens is that, and Dr. Linus Pauling, a brilliant scientist, made this incredible, important discovery that there is an abnormality in the hemoglobin chain for a substitution of valine for glutamic acid that occurs at the position 6 of the globin chain that results in an abnormality. This particular discovery, for which he won the Nobel Prize, is responsible for the modern day molecular biology period. That's it. That was the very first. Using crude methodology at that time. Okay? Now, the sickle cell is the result of genetic phenomena. There are 3 main genes that are responsible for the sickle cell disease. And they are BEN, stand B-E-N, come from Benin, part of Africa, Benin. CAR, C-A-R, from the Central Republic of Africa. And then SEN, S-E-N, from Senegal. These are the 3 genes that I stated before. There are sickle cell disease throughout the world. Throughout the world. There are places where sickle cell disease exists, and folks who wants to run away from their ancestry try to do everything possible to come up with another gene that is native to that particular area so as to disassociate themselves from Africa. This is crazy. You have folks, you look at them, you know they're black folks. Just because their hair a little straight doesn't mean they're Caucasian, and yet that behave like they think they are. It is absolutely it's incredible how psychology operates. In any event, be that as it may, sickle cell disease occurs not just in Africa or the Caribbean. It occurs in the Middle East. It occurs in India and other places as well. People don't want to talk about it, but it's there. As a matter of fact, there are more sickle cell disease in India than you have here because of the population is so much bigger. Be that as it may, these genes were brought to the New World when the slaves were brought in from the 3 different parts of Africa. And that's where the gene penetrate the New World, period. Now, when I left off, I was talking about hemolytic crises. Now, there are several crises. I'll go over them with you again. Hemolytic crisis, painful crisis, hypoplastic crisis, acute chest syndrome, priapism, splenic sequestration, and so on. These are the different type of crises. Now, to continue the discussion dealing with sickle cell crisis, hemolytic crisis, I will go over that with you in detail, but give me a second to again present this book to you before I forgot. The Best of Clinical Medicine for the 21st Century. This is a book that I wrote that came out about a month ago now. It has 110 chapters and 816 pages. It covers medicine throughout the world, not just in this country. If it has to do with medicine, high class, high powered, academic clinical medicine, you are likely to find it in this book. Of course, you can find the book in your local public libraries as well as online wherever books are sold, and there are always copies in my office as well. So now, what happened in hemolytic crisis is the fact that the normal red blood cell that people who don't have abnormal hemoglobin lives for 120 days in the human body. From the time that it was produced in the bone marrow, gets spilled into circulation, it lives 120 days, and then they died out. However, in somebody with the sickle cells, first of all, somebody with sickle cell anemia per se, the SS or the SC or the S-style, these cells live anywhere between maybe 20, 15 days in the human body, and then they died out and they release the content, which really completely messed up the body with bilirubin and iron, etc. When someone has sickle cell disease, any one of those three, there are 4 different types of disease associated with sickle cell disease. You have the SS, you have the sickle SC, you have sickle thalassemia, and you have SA, which is the trait. The SC is when a parent who's carrying the C hemoglobin gene has a child with somebody who's carrying the hemoglobin S, and the infant wind up with SC, okay? The same thing applies to sickle thalassemia when someone is carrying beta thalassemia, which is quite common, by the way, and I'm not going to talk about it today, is get a child with someone who's carrying the sickle C, either the SS or the trait, and the infant wind up with sickle thalassemia. There are significant clinical differences that I'll get into as I discuss each crisis syndrome differently. So now when you have the hemolytic crisis, the red blood cell burst, as it were, releasing iron and bilirubin and a lot of other noxious material into the bloodstream, okay? Now this would look like what a normal red blood cell look like, okay? The normal red blood cells look like. And then this is what a sickle cell look like. This was a target cell look like, okay? All right? So these things then, these cells are abnormal. And then when the cells are abnormal, they cannot navigate through the vessel very well. As a result of that, they get stuck. And the blood, the cell gets stuck to the wall of the vessel, wherever it is stuck. That itself creates a local inflammation. When the cell to vessel wall result in a local inflammation which worsens the whole process, and then you have plaque development, etc. Well, when someone is hemolyzing, they come in. Usually folks who have sickle cell anemia walks around with a hemoglobin maybe 9, 8, in that range, and they tolerate it very fine. However, when they're hemolyzing briskly, what causes the hemolysis, nobody knows. Sometimes it could be an infection, sometimes it's just stress, or God knows why, and they start hemolyzing. They're hemolyzing briskly. They drop the hematocrit hemoglobin down to 6, sometimes 5. It's a critical situation. They have to be brought into the hospital, have to be evaluated to look for a source of possible infection if one exists, and they quickly have to be given oxygen, and they also have to be given red blood cell transfusion. Now, last week I mentioned this very important concept. It's a very important clinical concept. If you're going to transfuse somebody who is briskly hemolyzing and they are chronically anemic and they have sickle cell disease, which means they probably have disease of the brain, disease of the heart, disease of the kidney, disease of the eyes. That's wherever those vessels go, and the blood has to go everywhere, there's likely to be problem associated because of the sickling phenomena. So these people have bad heart, bad brain, bad eyes, bad kidneys, etc., bad liver, bad spleen, what have you, bad bone, etc. So you're going to transfuse the individual, you have to be very careful. This is where the knowledge of basic science and basic clinical hematology comes in. Somebody shows up, they're very anemic, you're going to transfuse them. The blood is in the blood bank, stays there, is good for 42 days. Those are the rules. There's nothing wrong with it, it's good for 40 days. However, as the blood sits in the blood bank, there's a substance called 2,3-DPG, which is needed to keep the blood fresh. And as the blood sits in the blood bank, the 2,3-DPG begin to decay every day. The older the blood, the less the amount of 2,3-DPG is in it. And without 2,3-DPG, the blood is pretty much useless. You might as well give the patient normal saline, okay? Now, why is that important? Well, if somebody is already severely anemic, which means they're really ischemic at this point, which means they're getting lack of oxygen, there is a concept in the human physiology called the oxygen dissociation curve. If you could look at this invisible curve that's right in front of you, right here, to the left of the curve is bad, to the right is good. To the left, the red blood cells are holding onto the oxygen. When this curve is shifted to the left, the red blood cells are holding onto the oxygen that attached to the hemoglobin. They're not going to deliver it anywhere for the benefit of the rest of the body. However, when the curve is shifted to the right, the red blood cells are very freely, easily releasing the content of oxygen they're carrying to perfuse the body. So far, so good, okay? Now, here's the deal. When you transfuse this individual who's chronically sick and need a blood transfusion, severely anemic, hypoxic, meaning lack of oxygen or low oxygen, as you put the red blood cell into the person's vein that is deficient in 2,3-DPG, that red blood cell, it ain't going to do any good, because as soon as it gets into the system, it shifts the oxygen dissociation curve to the left, because it is deficient in 2,3-DPG. Therefore, the red blood cell you're giving in ain't helping the patient as far as oxygen delivery is concerned. Volume, yes, but not oxygen issue. So therefore, the sicker the person who has underlying brain disease, heart disease, kidney disease, eye disease, you need to give them fresh blood that is rich in 2,3-DPG, so that as the blood enters into the vein, automatically the oxygen dissociation curve is shifted to the right, thereby allowing oxygen to be freely delivered to the tissues that need to be perfused. And all tissues, all organs need to be perfused properly with right amount of oxygen. That is a very important concept. Now, it is the job of the treating physician, and no one should be treating people with sickle cell disease acutely sick without the help of a hematologist in the first place. Then the hematologist then will go to the blood bank and ask the blood bank very politely, very kindly, I have this patient that I have to transfer. It's a special situation. Can I have blood that is reasonably fresh, a week or 2 weeks old, 3 weeks old? And almost 100% of the time, the technician will oblige. I know. I worked in the blood bank for many years as a medical technologist myself. I know everything having to do with the blood bank. I know it. I used to sleep on the counter of the blood bank to take a nap in the middle of the night. So I know it, 7 days a week. Now, if the doctor doesn't do that, it is the job of the blood bank technician to properly manage the blood bank. Because the idea, you don't want the blood to expire. Blood is very precious. You don't want the blood to expire without using it. So every single day when we work in the blood bank, it is our business to manage the date of the different unit of blood that's in the bank so as to use it as quickly as we can ahead of the fresher one to properly manage the blood bank. Because blood is extremely precious. The blood is good, but it's not good for this particular patient in this particular setting. Now, this does not necessarily apply just to sickle cell or disease or anybody who's hemolyzing. It applies to any patient who's got underlying heart disease, any patient who has underlying brain disease, any patient who has underlying kidney disease. It's applied to them, because if you're going to transfuse them, you must put that thought, that concept in front of your head and use it. Now, it isn't for me to tell everybody what to do. That's not my job. Suffice it to say, I do not have a monopoly to this information. This is classic academic clinical medicine that I teach, that others teach as well. People who don't know it, well, ain't my fault, okay? It isn't my fault. I'm not going to sit here and apologize for the fact that I have devoted 42 years of my life teaching and practicing and reading and writing and non-stop 24/7. Okay, so suffice it to say, you now transfuse the patient. You got to be very careful, however, because the patient has underlying heart. You can't have sickle cell disease for any length of time, don't have some degree of cardiac disease. So therefore, and the patient also has been accustomed to the low hemoglobin for a long period of time. So there's no need to rush pumping 2-3 units in this patient right away. You're going to throw them into congestive heart failure. That's bad clinical medicine. So what you do is that you very clearly will give the patient the blood, and if you need to give them intravenous diuretic at the same time so that they can urinate the excess fluid, that's the right thing to do. So you do that, you transfuse them very carefully, 1 unit today, 1 unit tomorrow, very carefully, and then you watch the level of the hemoglobin, and then in addition to that, you give them folic acid. Now this is how, what is the need for the folic acid? Well, here's the deal. As anybody is hemolyzing, you're also using folic acid in an attempt to make new red blood cells. So everybody who is hemolyzing is relatively folate deficient. Let me repeat that. Everyone who is hemolyzing, regardless of the cause of the hemolysis, is relatively folate deficient because the body is trying to grab onto anything it can to make new red cells. And the first thing we will grab onto is folic acid. So therefore, you have to provide sufficient folic acid for this individual. And here we go. 1 milligram of folic acid is what we use for nutritional purposes. Even though we give 1 milligram of folic acid, the body in a normal setting is only capable of using 400 micrograms. That's the physiology, okay? We don't have a 400 milligram tablet, so we give an individual a milligram tablet. That is the therapeutic thing to do. That's it. That's for nutritional purposes, for women who are pregnant, to prevent neurotubal disease, etc., etc., for people who are abusing alcohol, and so on and so forth. We give them 1 milligram of folic acid, etc. Okay? Now, when it comes to hemolytic disease, such as sickle cell anemia, this is a different story. This individual should be receiving 4 milligrams of folic acid 4 times a day, even though I have literature to show you that the recommend is as much as 25 milligrams per day. Williams' textbook of hematology, I don't know if it's still around, the textbook that is, recommend 25 milligrams of folic acid per day for somebody who's acutely hemolyzing. I use 4 milligrams 4 times a day. And you would expect to get a phone call from the pharmacist. You just explain to them what you're doing. This is clinical medicine. I know what I'm doing. Leave me alone, blah, 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 blah. Okay? Because if you don't provide sufficient folic acid for this patient and oxygen and fresh red blood cell, you're going to get yourself into trouble. So, or the patient is going to get into trouble as well. So you have to give enough folic acid to keep up with the red blood cells that are dying so that you could produce new one. So that's how you manage this individual. Once they stabilize, the hemoglobin stays up, the bilirubin goes down, the reticulocyte count is at a reasonable range. You got to be very careful. You cannot, let me repeat that, of all the things that you have to do when you run into somebody with sickle cell disease that's acutely sick, you need immediately to know what is the level of reticulocyte. Very important. Because if you don't know the level of reticulocyte, you don't know how bad the situation really is, because reticulocyte, those are baby red blood cells. If the patient is capable of spilling new red blood cell into the circulation, that patient is going to be okay. The bone marrow is capable of making new red cell. It's just a matter of time because things simmer down and the patient is going to be okay. However, if for the sake of argument this patient is hemolyzing as I described it to you and the reticulocyte is very low, that is major trouble, because that's called hypoplastic crisis, which brought me to the second sickle cell crisis that I want to describe, which is the hypoplastic crisis. What is that? I just told you. Patient is hemolyzing, they have sickle cell disease, they come into the hospital or in your office and they're sick looking, whatever, your other reticulocyte count is low. What is the reticulocyte count? The reticulocyte count is that baby red blood cell will stain the smear of the blood with gram Giemsa, then we dry it out, put a little oil on it, cover it up, look under the microscope. We count 100 cells, and then the percentage of baby red blood cell within, and that, you can't miss them because they're very darkly stained. Why they're darkly stained? Because they have RNA. When the cell is not fully developed, it has not shedded the RNA within it. So the RNA is stained by the bluish stain. It looks blue under the microscope because of the RNA that's inside the red blood cell. When the cell is completely mature, the RNA has already been gotten rid of. But the more immature the cell is, the bigger it is, and the more bluish it's going to be. And the chapter that I have in this book dealing with folate deficiency, B12 deficiency, I showed the cells that coming from the bone marrow has their stain, the cells that are coming from the bone marrow in folate deficiency, how dark bluish they are, and I have examples of that in this book. Okay, so that's, then you count 100 and you get the percentage of reticulocyte count and you report it. If the patient is hemolyzing, low red cell and the low reticulocyte count, that is a whole lot of trouble. Okay, that's a whole lot of trouble. That means something happened that's preventing this patient from producing red blood cell. That's red blood cell hypoplasia or aplasia. Hypoplasia means low production, aplasia means none. Something happened. That something almost always is an infectious process. There are several viruses that can shut down the ability of the bone marrow to produce red blood cell. You're going to lose that patient if you miss that. So you can't talk about treatment for a patient who shows up with reticulocyte, with sickle cell anemia without knowing what the reticulocyte count is. It's very important. And then now that the patient is not making any reticulocyte, what do? Well, first you transfuse them with fresh red blood cell, as just mentioned. Then you try to find out what's the source of the problem, what's the infection. Is it bacterial? Is it viral? Is it fungal or whatever? Okay, you look for that to find out what's going on. Is it HIV? Because remember, people who have sickle cell disease have been transfused multiple times. They're prone to get infection, or is it hepatitis for that matter? It could be hepatitis A, it could be hepatitis B, hepatitis, it doesn't matter. Okay, that can shut up the bone marrow. So it is the job of a doctor to figure out what's going on. But suffice it to say, it is a very dangerous crisis, hypoplastic crisis. So we talk about hyperplastic crisis, which is hemolytic crisis, and we talk about the hypoplastic crisis. So these are the two crises that I've described to you so far. Okay? And the third one, of course, is the painful crisis. The painful crisis is a situation in which the individual is suffering from severe pain in the joint, severe pain in the bone and the liver, swollen liver, swollen spleen, headache, bone pain or whatever. So the patient is having what's called painful sickle crisis, and it is horrible. Painful crisis, the people come in since childhood. They've severe recurrent pain all over the body. And the question is, what's causing? Well, what's causing is because these cells clogged up the vessel, preventing oxygen to be carried effectively. So this area that is where there is lack of oxygen, you have cell clogging to vessel, releasing something called kinin, which is burned like crazy, causing the pain. It is ischemia. Okay? Now, it is inevitable, as one can well imagine, for individuals who are suffering from painful crises not to ultimately develop some form of addiction to the medication that they are getting. Now, here's the deal. A lot of people will rush and give these people Demerol. It's a no-no. It's a no-no because the Demerol, though it is a painkiller, this part of it that works is a breakdown product of the Demerol that will kill the pain. Unfortunately, that also can be very toxic to the human body, leading to seizures, etc. So the last several years, people have learned, especially hematologists, to back away from Demerol because of what I just explained. People have developed seizures because of it's a good medication. Just the fact that the breakdown product of it, what you have to go through for it to find to the part that works, can cause seizures and a lot of other problems. And it's extremely more addicting. So what we will do, we get these people morphine or give them Dilaudid, and we go between morphine and Dilaudid. Also, it's a very smart thing to also give them an NSAID, because I just told you there's inflammation going on, and the NSAID will take care of the inflammatory processes. So you give them NSAID, and you try to work with this individual. It is not their fault that they are addicted. It's that they've been getting this medication since childhood, sometimes 2 or 3 times a month they're in the hospital. Okay? And it is human nature, it's physiology. So they become, so do not deny, let me repeat that, it would be cruel to deny this individual the right amount of painkiller they need in order to relieve the pain. I don't know, I've been in pain. I happen to be someone who's allergic to every painkiller. I don't know how, that's how God made me. So I suffered through pain, having no way of getting any relief because I can't tolerate anything. I'm allergic to all of them. And Tylenol did pretty much nothing for me. So I suffered for months with it. So I am very sensitive to that issue. Listen, I'm going to stop here. Next week, I'll continue to talk about sickle cell disease again. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.